Hello, everyone, and welcome to this webinar. My name is Natalie Richardson. I'm the Managing Director at Save Your Skin Foundation. I welcome you to today's webinar presentation titled Patients Redefining the Future of Healthcare in Canada Summit, The Starting Line. This webinar will be introduced and facilitated by Louise Binder, Health Policy Consultant. It will review concepts presented at last year's summit, A Dose of Reality, Patients Redefining the Future of Healthcare in Canada. Presentations will include recordings of Jennifer Clawson, Health Systems and Value-Based Health with Boston Consulting Group, and Dr. Ambreen Sayani, Health Strategist and Consultant, St. Michael's Hospital in Toronto. There will be time for question and answers in between these presentations and at the end of the session. Discussion that Louise will host is surrounding this review will prepare attendees for the 5th annual Patients Redefining the Future of Healthcare in Canada Summit. That's a long one, Louise. being held virtually this year, of course, and it will be in several short sessions on November 30th, December 3rd, 8th, and 10th, 2020. We will get started on the presentations in a moment, but first a few logistics. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. There will be questions and answers throughout the presentation. You'll see at the right-hand side of your screen an option to type in a question under the word chat. Please feel free to ask your questions throughout the presentation, and we will do our best to answer them in the allotted time. If there are any questions that do not get an immediate answer, we will contact you with a reply and any discussion you wish to have after the webinar. Thanks again for joining us. We'll now begin the presentation. Louise, I am honored to introduce you. It's an honor to work with you. I'm looking forward to hearing your talk. So over to you.
Thank you so much, Natalie, and thank you for all the hard work in putting this webinar together for us today. I would like to thank all of you for joining this webinar. As Nat said, I'm Louise Binder, and I would like to thank all of you on behalf of the organizers of the summit, including Save Your Skin Foundation, the Canadian Psoriasis Network, and our most recent new member, Sharon Clark, Associate Director, Office of Indigenous Initiatives, and Office of the Provost and Vice President at Queen's University. I'd also like to thank the Conference Board of Canada for joining us to organize the value-based healthcare panel of the summit, which is on day 3. I'd like to begin by acknowledging the Indigenous peoples of all the lands that each of us is on today. While we might be on a virtual platform, from coast to coast to coast, we acknowledge the ancestral and unceded territories of all the First Nations, Inuit, and Métis people that call these lands their home. We affirm our commitment and responsibility to improving our own understanding of our local Indigenous peoples, including First Nations, Inuit, and Métis, and to improving relationships. Please let us reflect and acknowledge the harms and mistakes of the past that continue, and to consider how we can each, in our own ways, move forward with meaningful efforts toward reconciliation. I would also like us to take a moment to remember those who have lost their lives over the past devastating year, whether or not directly or indirectly from this pandemic. We miss them all. I send well wishes to those who are ill and wish them speedy recovery. I heartily and sincerely thank first responders and other healthcare workers who have and still are working long, difficult hours on behalf of people across this country and in other countries as well. Never have the issues of the sustainability and effectiveness of healthcare systems and delivery been more in the forefront of people's minds than they are today. Never have patients felt more that they need and are entitled to a meaningful voice in the future of these systems upon which their welfare, our welfare, depends. Our summit provides one place for that crucial voice, collectively and individually, to be heard. This webinar, as Nat mentioned, is intended to provide awareness to those who've not had previous knowledge of the concepts of value-based healthcare, and or the social determinants of health, because these concepts are at the heart of the values that we hold at the virtual 5th Annual Patients Redefining the Future of Healthcare in Canada Summit in 2020, that will take place over 3 sessions for all registrants and a fourth for patients, patient representatives, and caregivers. We can talk about why these are our foundational principles later if you'd like, and certainly more about how the summit will move forward. One thing I will say in advance, and that is that we as patients must make our voices heard, all patients, during this terrible time. After the presentations, as Nat has mentioned, after each one, I'm happy to take specific questions about that presentation. And then at the end, we can have general questions about either presentation or about the summit, or actually about anything you'd like to ask. So without further ado, please enjoy the presentations from our 2019 summit on these topics.
Great. Well, thank you very much for the invitation. This is a bit impersonal from my side, and I apologize for that, but I thank very much the opportunity to speak with you today. And I understand the schedule pressures, and also want to thank the AV folks who have worked hard to get this all set up appropriately. Let me go through a couple of slides here, but I also want to make sure that we leave time at the end to talk openly with any questions and comments that you may have as well. So just to back up a step, my name is Jennifer Clawson. I've been working in healthcare for roughly 20 years, and about half of that time working on the topic of value-based healthcare. I'm actually based in our BCG Madrid office, but work more outside of Spain than inside of Spain. What I wanted to do today was, first of all, start with a story about a patient, recognizing the value and the reason why we're all here today. This is a little girl who's suffering from cystic fibrosis, and if she had been born when I was born, she wouldn't have lived roughly past the age of 5. But it's thanks to some pioneering folks who decided to measure the outcomes that are most important for cystic fibrosis patients, and to do so systematically, that she and others like her have a much longer life expectancy and a much fuller, richer life today than they would have 30, 40, 50 years ago. And so this is the tribute to what gets measured gets done, and a couple of key clinicians who were working in the cystic fibrosis space back in the 1960s and 70s were asking themselves, if we're not measuring the outcomes, how can we actually tell what we're doing for patients? How can we actually make sure that we're actually delivering the best, the value and the best outcomes for them? And so this was the early stages of the development of what's now the Cystic Fibrosis Registry in the US, which is, as you all know, not thankfully affecting a significant portion of the population, but which through its efforts as being a national registry and pulling together all of the sites across the country that do treat people with cystic fibrosis, has actually been able to move the needle, as they say, significantly in terms of life expectancy. So just to share a picture of that, as I said before, if this child had been born 30, 40, 50 years ago, the picture would not have been nearly as positive, whereas now the people who are born with a cystic fibrosis diagnosis are expected to live into their 40s. And one of the things that I think that's interesting, and we'll come back to in a moment, is that, you know, this here is a very crude measure of an outcome that matters to patients. I would argue that it's actually something that a patient would have as an expected or a given, their survival. But what's interesting is that the registry itself has shifted and now has a large number of measures that go more into the quality of life that these patients have. And so, for example, on the questionnaires to cystic fibrosis patients today are questions such as, do you have goals of higher education? Do you have goals of establishing a family? Something that, again, 30, 40 years ago would have been unheard of. So with that as a starting point, I wanted to talk about a couple of things today. First of all, I've been asked to talk about why value-based healthcare now. What's the pressure? Why do we actually care now? What do we mean by value-based healthcare? Because there's probably not quite as many definitions as there are people in the room, but quite a few to be sure. Um, Importantly, how is patient care actually improved by using the tools and moving more towards value-based healthcare? And then finally, leave some thoughts on, where we can go next from here. So first of all, why value-based healthcare now? And I want to start with a couple of the key challenges that all of our healthcare systems, Canada, US, Spain, et cetera, are focusing on. And at the root of all of this, as we all know, is that healthcare spending is growing faster than GDP. I could have picked any number of countries other than the 6 that are on this slide here. But as you can see that the healthcare spend line in all of these 6 and many other countries as well is growing faster than the GDP is growing. And that is in addition to the high and in some places increasing rate of GDP that we're spending on healthcare. It's just not allowing us to afford the innovations that are most meaningful and most helpful to patients because of a lot of the challenges that we're facing. In addition to simply the economics of the healthcare spend growing faster than the GDP, if you dig one layer below that, in fact, a lot of our challenges come from the fact that spending is wasted, unfortunately. This can be from inefficiencies of doing tests in multiple places because records don't travel with patients. It can be done by using devices and tests that actually don't have a positive proven impact on the outcomes itself. So I don't want to get into all the details on this slide, but one example to take the second line there, you can see there's something called these space suits. These are single-use suits which are worn by clinicians in an operating theater that have a cost on average of 400, 500 euros. That when tested in a couple of different hospital settings, were actually not shown to have a decrease in the infection rate for the patients where these were being used. So it's one example, but there are many out there that actually add cost to the overall treatment pathway, but actually don't have a positive impact for the outcome for the patient. But in fact, actually, for me, what must be the most critical of these 3 challenges is one that I view as being more silent or more hidden. And that is that there's significant outcome variation everywhere we look. So you can see a couple of examples on this page here, but if I were to look at it within a country, within a region, across countries, wherever we look at it, we see that in fact, the outcomes are hard to get your hands on, but then when you do get your hands on them, you can see that there's significant variation. So just to give an example here, 3 lines down, we see a 6x variation between those hospitals that have the best rates of readmission after hip surgery in the UK versus those that have the worst. Similarly, in Germany, we have a variation in reoperation rates after hip surgery of 18x. There are a lot of hospitals in Germany, but the 18x is a very, very significant, and I would almost say a hidden problem because we just don't have the transparency on these. When we do have transparency on outcomes, such as the case with the Cystic Fibrosis Registry or other similar registries or transparency efforts, we quickly see that clinicians are striving to be better. They strive to improve their care. They strive to improve the outcomes. And even without additional enablers, such as changing the way that people are paid or incentivized, the transparency of the outcomes alone has a significant improvement effect. So those are some of the challenges that I particularly feel are relevant in terms of why value-based healthcare now. But let me step back again and say, what do we actually mean when we talk about value-based healthcare? And I want to take you through the definition that was developed over the past couple of years by a project run by the World Economic Forum. So BCG was the knowledge collaborator together with the forum, and we had leaders from the CEOs, for example, from Novartis, from Medtronic. We had the head of Kaiser Permanente in Intermountain. We had the head of NHS in England. We had the Minister of Health in the Netherlands, etc. And so at the end of the day, the definition that we came up with by default is actually very much a multi-stakeholder view of the system. It's all based around the patient at the center, though, the patient and the population. So that's why we start with this image here. And at the root of it, for those of you who may have read works by Michael Porter or others who have written about value-based healthcare, is very much this very simple equation of the patient outcomes, those outcomes that matter most to patients, over the cost to deliver those outcomes. And that in itself is called value. And so value can be improved either by improving the outcomes and or lowering the total cost to deliver those outcomes for a particular patient population. But that in and of itself is not necessarily the unit of analysis that we need to think about. We actually need to think about it on a population segment basis. And we use the word population as opposed to patient because we want to include preventive care as well. So not only once somebody has a diagnosis, but we also want to think about value-based healthcare as it applies to the adult healthy population or newborns in terms of prevention and vaccines. But more typically, it's used today, as you're well aware, with those patients who have one or more diagnoses. And so that's the unit of analyses that we're looking at, the outcomes that matter to those patients who fall into a similar patient population. It's also relevant to look at it in terms of the segment-specific interventions. So for a patient, for example, with prostate cancer, these segment-specific interventions could range from watchful waiting to a more proactive stance of surgery, drug treatment, etc. So its intent is to include all types of the interventions possible for the particular diagnosis and for the particular patient population. At the end of the day, it's a very data-driven approach. So we need data on the outcomes in order to be able to drive the best practices and the learnings. So it relies on developing informatics, health informatics, and one of the underlying pillars of that is interoperability so that we can share data across our own local systems, but also then more broadly across systems in order to use that data to do benchmarking, to figure out what the best practices are, to do further research on both drug development and treatment development, as well as new care pathways and decision support tools for clinicians. Now, there's an element obviously about delivering the care. What value-based healthcare is not about is, say, optimizing the number of primary care doctors or developing more tertiary centers. Instead, it has at its root, going back to the center of the diagram, the outcomes and the costs. And so it's about figuring out for the patient population at hand, what's the best way to organize care for them? Now, in some cases, that could be more home care, that could be more of telehealth consultations and the like. So it's really, again, operating around the core of this, which is the patient population. Obviously, payments and incentives are a critical part of this. Ideally, what we want to move away from is pure fee for service, because that has some disincentives and associated with it that don't allow us to move the value paradigm. But in fact, there are many different ways that we can incentivize and pay differently as long as we're moving away from the disincentives associated with fee for service. And finally, this has to operate within a system that has policies and regulations which are both supportive, but also make sure that they do not prohibit the development of value-based healthcare. So I've hoped that that gives us a good starting point and a common definition across the stakeholders. Let me turn to what really is critical about this and what makes it different, say, from some of the other ways of thinking about healthcare transformation. And that, at the end of the day, really comes down to the outcome side of it. People have been looking at costs for decades, and unfortunately, we saw the graph before. It hasn't moved the needle. The costs are still growing faster than other elements like GDP. But it's really about the outcomes. That's something that we've seen increased focus in the last couple of years. And let me take a moment then to think about what outcomes are. When we define outcomes that matter to patients, it's sometimes easier to start with what we don't mean by outcomes. We do not mean that outcomes are the initial conditions. We do not mean that outcomes are the processes of care delivery. It also is not an outcome to think about the structure of your hospital certifications, your facility standards, and the like. And finally, there are a number of clinical indicators that some people may ascribe to be outcomes, such as in this case on this slide, we're seeing an example for a patient with prostate cancer. And those indicators would be things such as the PSA score, the Gleason score, the surgical margin. But in fact, those are not truly outcomes that matter to the patients. They're necessary things to measure so that we can identify the right treatment choices. But if we really focus on what are the outcomes that matter to patients, these are things in this particular example, again, being a patient with prostate cancer diagnosis, these are at the first level survival. Then they come to more specific outcomes such as continence, erectile function, and anxiety. Now, all of these outcome categories here are ones that have a cost to the healthcare system, and increasingly where we see them being measured and actively monitored, we see that not only do the outcomes improve, but the cost to deliver those outcomes actually is able to be controlled and come down overall. Now, we have a lot of different ways that we could talk about outcomes. There's an organization that many of you may have heard of called Icham, which stands for the International Consortium for Health Outcomes Measurement. Now, Icham is an independent, not-for-profit organization which was co-founded by the three organizations on the left, BCG being one of them. And it's essentially set up with its mission to define a minimum standard set of outcomes by patient population. And so you can see on the right-hand side some of the examples of those sets which are already developed. There are now 28 sets on the website available for download. They're openly available. And those are tackling over 50% of the global disease burden in terms of spend. Now, the way that these sets are designed is by having the leading global experts clinically come together with patients or patient representatives through a process that's roughly around 6 months to build consensus. So they start by figuring out what are the main domains or the main types of outcomes that matter to us for this particular patient population. And then they go through a literature review of existing measures to figure out for each of those domains what would be the set of measures to recommend. And then you can see in the bottom corner there that each of those different color shades of green is one measure. So at the end of the day, we're not talking about hundreds or even tens of measures here, but we're talking about a fairly small number, with the goal being that these would be measures that are standardized. Any institution or any clinician can measure beyond this and obviously will do so. But at least if we agree on these common minimal standards, then we can start to do some benchmarking and some comparison in a broader setting. So Icham started back in 2012, and it's as I said before, an open platform for people to go onto and look at. We know that there are at least 30 countries and over 650 organizations. I've actually heard more like 1,000 organizations now using one or more of the Icham sets, but it's hard to know because, as I said, this is no fee or registration required to use them. Interestingly, it's also something that has been in collaboration with the OECD. You may have heard about this Paris program, which is about patient-reported information systems and outcomes. And so Icham is collaborating with OECD on that practice. Interestingly, also for the academics in the room, for the majority of the 28 sets, as soon as they are finalized, the working group for that particular set submits it for a peer-reviewed journal for that particular population. And so they are published shortly after being finalized. Let me then switch gears and talk briefly about, how is patient care actually improved with value-based healthcare when we see institutions implementing it. And let me choose an example, which are 7 Dutch hospitals. These are there's no common structure, ownership structure across these. There's 7 independent hospitals. As you can see, Netherlands is a fairly small country, but they're located in dispersed parts of the country. And what happened a couple of years ago was the CEOs got together and said, we want to pool our resources, and for ourselves and for our own hospitals, we want to start to understand what best practices are for particular patient populations, measure those outcomes, and compare our results. And so what they did was they looked at it a bit differently from historically in terms of, by department within a hospital. So typically you would have the head of cardiology, the head of internal medicine, et cetera. They still maintained that organizational structure, but what they did in this study was to actually look at it on a patient flow. So in other words, a breast cancer patient would touch many elements in the hospital, and they use that as a unit of analysis, so the patient's population. And you can see here, breast cancer, prostate cancer, and cardiovascular are 3 of the first patient populations they've done. They've now increased significantly, and they have a group that's monitoring this and adding to it new patient populations every day. The process they went through was effectively, first of all, to establish a multidisciplinary team at each hospital, but also then a team across the 7 hospitals, define the scorecard and what they wanted to, in terms of what they wanted to measure. And then every 6 months, they would go through a process whereby within each hospital, they would collect the data, analyze it, and identify the best practices. And then across the 7 hospitals, do the same so that they could figure out and learn from each other. Again, Holland is a small country, but as you'll see in a moment, the differences were quite large. So let me spend a moment, first of all, just to talk about the team. So the multidisciplinary team they formed, you can see here on the slide, it's not rocket science. I mean, you would expect that if you were to gather the people who are treating breast cancer patients, these would be the roles that you would expect to see. But 2 things I think to note. One is that they did include the patients, which is not always the case. So I think that's a best practice that we've seen in other hospitals as well. And whenever they are included, it keeps everybody on the same page. It keeps everybody honest and brings a different perspective that's sometimes lacking, to be completely honest. But the other thing that was interesting is that even though these professionals all treat breast cancer patients, they hadn't necessarily even met within the same hospital. So in one case, we had a surgeon as well as a nurse in recovery who had both been working there for more than 10 years each at the same hospital, but had never met, even though they treated the same patients. So as soon as you start to bring people together around a patient population, as opposed to in their typical organizational structures, you start to see some different conversations taking place and some quick ideas in terms of improving both patient care and then thereafter having an impact on the outcomes. The other thing I just wanted to share was a simplified version of their scorecard. They didn't have more than 20 measures on this. I've just chosen a couple of here to highlight. But you can see that basically they fall into 3 main categories, with the 4th being the treatment mix. So outcomes is the starting point. And as I said before, that's mostly been what has been lacking in other healthcare transformation efforts. Some costs and some processes. Now, let me say a little bit about each of these in turn. On the outcome side, they started with patient populations that did indeed have Icham standard sets already published and available. And they looked at each of those sets and made a selection. So they very pragmatically said, look, there may be 12 items on the breast cancer set, but feasibly across all of our 7 hospitals, we can really only start by measuring 7 of those. So let's start with these 7 and see where we get to, with the goal of adding over time. And on all of the outcome measures for Icham, and what this group of hospitals also did, is you can see that the first one is an example of a clinical outcome, so something that the clinical staff would track and monitor their own progress on, as well as a patient-reported outcome. And here, some quality of life measures that came from the Icham standard set recommendations. Beyond outcomes, the costs you can see here are in fact not euros or not dollars, but instead, because wanting to avoid any complications about different salary levels, different staffing levels, et cetera. Uses of resources that would be something that's comparable across different hospital settings, different clinical settings. And so here you see two examples of some of the main cost drivers. And the processes were included, a couple of them. I think there were no more than 5 or 6 processes out of the overall 20 measures, roughly. And the reason for choosing these processes were because they were expected to be the root causes of some of the variation in either the outcome side or the variation on the cost side. And finally, although this was not something that they looked to do in a peer-reviewed journal on their first pass, but it was much more around a learning system, they did start to include more of treatment mix variables for risk adjustment. And even before they did significant risk adjustment, they already started to find meaningful differences, which they could have an impact on in a fairly short period of time. And so let me share with you briefly then some of the results that they were generating. This here you can see is the 7 different hospitals, their starting point on one of the metrics. This is for, again, the breast cancer example, and the particular measure here that we're looking at is the reoperation rate due to positive margins. In a small country such as the Netherlands, in these 7 hospitals, you already could see a 4x variation in this one metric. And that was similar across the other metrics they chose, and surprised them, to be completely honest. They were not expecting this level of variation among their 7 hospitals, and worked over time to reduce that fairly quickly. So this was the starting point, as I mentioned. And then what they started to do is they started to have discussions around, well, how is it that you do your surgery? How do you define the right margin? What are the steps you take? And it came down to some best practices, such as those with the lowest rates actually used an echo during the surgery before the patient went to the recovery room to make sure that they had indeed recovered or removed all of the tissue. And there are other examples like that. So once you have people reviewing the practice, seeing the results, seeing the outcomes, then you can quickly identify what the best practices are using a data-driven approach. So after, you can see here, this is cycle 1 and then cycle 3. As I mentioned before, a cycle is 6 months. So this was basically 12 to 18 months later. You can see that overall, there's a 17% positive improvement on the reduced reoperations from the positive margin. So that's the improvement overall. And you can see some of the those who had the outliers made indeed the biggest improvement rates. So I think it's a positive effect. And I think one of the things that's not captured in these numbers here, but when you talk to the people who are in the hospitals here, they are just thrilled with this approach. And in fact, the guy who runs the overall value-based healthcare across all the 7 hospitals has people knocking on his door saying they want to be the next group. It's changed the way that they cooperate. It's changed the way that they engage with patients. And it's obviously had a positive impact on the outcomes for those patients. And so in the interest of time, let me just make a couple of comments on where we might be able to go next and what are some of the things that we need to keep in mind as we move towards value-based healthcare transformation, and then open up for questions. It's not easy. Otherwise, I think everybody would be doing it so far. And we have gathered some learnings from where we've seen this being implemented in various places around the world. Some of the things that make transformational change with value-based healthcare hard are the fact, first of all, that there's actually no single one authority to mandate the change. In most cases, we're operating across different types of stakeholders, across different institutions, and none of those has necessarily the leadership to actually mandate the change. Secondly, there's a level of conflicting goals and incentives across the different stakeholders. I mean, historically, that's what's partially gotten us into this issue, where the goal of, say, very crudely, to put it, say the goal of pharma and med tech is to play the volume game times the highest price they can, whereas, for other industries, it hasn't been the goal to have the patient at the center. The commitments to change are typically something that's hard to enforce and hard to keep momentum around over time. In addition, there's no shared culture. Each of us is used to working within our own organizations. We partner on various initiatives from time to time, but getting a common culture to drive change across these institutions makes it hard. And finally, even just the logistics. We don't all share, as is seen today, we don't all share the same AV platforms or the same calendars or the same ways of working. So those are other challenges. And so at the end of the day, there's challenges around authorizing the multi-stakeholder work. Who's the actual authority that should be driving this? And in fact, there actually is no one authority to be doing so. And then once an initiative is identified and starts moving forward, how can we actually maintain the momentum? And there are challenges around holding the people together to cooperate for the longer term. So what have we learned from this, and where have we seen some of the best practices, both at Santion but other places as well? And I think it all starts with a shared understanding of the problem. So spending enough time with sleeves rolled up, and as somebody once commented to me, eating bad sandwiches and cold pizza is one way to really get that common vision for change. A second element, I think, which is a hallmark of the successful initiatives, is having a broad network of champions. So, for example, it doesn't have to be the Minister of Health or the mayor of the city or the head of the hospital, but rather each of the participating institutions needs to have a series of champions to connect the institutions and create that web of champions. Then also, I think there's a lot about setting the right collaborative environment, giving permission to both test new things out, but also building on trust. Again, there's a lot of lack of trust in the healthcare industry, broadly speaking. And so this works well on a small scale, getting to know individuals and then working over time in a collaborative way and building up that trust. And then finally, we've seen, neutral full-time project management is one of the critical elements to this. And in fact, there's an initiative ongoing, which is a carryover from the World Economic Forum project a couple of years ago in Atlanta, where some of this project management is actually coming from a patient association. So the American Heart Association is actually providing some of that neutral full-time project management, well-respected and neutral versus some of the individual hospitals, the payer associations, and pharma and med tech. So let me conclude with this slide here, where, to me, value-based healthcare is really about working together. It's around not necessarily doing radically different things, other than starting to have different types of conversations, always keeping the patient and the patient population at the center, and focusing most on the outcomes that matter to those patients. So the African proverb says, if you want to go fast, go alone, but if you want to go further, go together. And so I think this is very much, for me, what sums up the transformation, successful transformation around value-based healthcare. So let me pause here and open for questions.
So questions or comments, I'll figure out technically how we are conveying them to
Okay, somebody's asking
Jennifer.
a question. I can't hear it.
Yeah, we might have to type them in. So let me just figure that out. But does anyone have any questions or comments?
Hi, Jennifer. It's Louise. I'm interested in how you include social determinants of health in your patient-reported outcome measures to make sure you hear from populations that often aren't heard from in terms of their values.
Okay, Louise, I understand, has asked a question. Interested in how we include social determinants of health in getting patient health in populations that are often not included. That's a great question. And I think that, in fact, if we start with the patient outcomes, and, you can think that there are many patient populations that don't yet have proper outcome measures defined or tracked in a meaningful way. I think it's around starting with the most basic of those. So there's a common set of PROMS tools, or patient-reported outcome measures, that can start to get at some of the social determinants, but also also populations that are often not included. And these are standard ones that are going across different patient populations, so it's not specific for a one diagnosis, but I think those are common ways of starting to get those marginalized populations included. And so essentially, I think one of the key elements of making that a success and bringing those in is finding a way to capture that data. And capturing that data can be done the old-fashioned way, which is some hospital organizations actually hire nurses to do outreach, telephone outreach, and conduct the PROM survey over the telephone, and they can therefore control the responses, make sure that they actually get the responses in, etc. And increasingly then on the other end of the spectrum, we see a lot of these patient-reported outcome tools being available on mobile apps, and something that is both prompted then from the patient on a regular basis with an easy to fill in set of questions on the app itself. I hope that answered the question. This is tough without any feedback.
One more simple question. No compound complex
I can hear.
sentences.
I can hear.
Oh, you can hear?
Yes.
Oh, good. Okay. 'Cause I was like, I was trying to do it for typing. So with the Dutch study, with the 7 hospitals, I represent a patient organization, and we're very keen on this looking at outcomes between centers, let's say. How did you overcome the professional fear of comparison? Who drove, there had to be some leadership around overcoming the kind of fear of that professional comparison between surgeons in the case of the breast cancer example. I'm curious about how that was overcome.
That's a great question. And it's one that's always present when people start to do this. They always say, well, my patients are sicker. It's not a fair comparison. The data is wrong, etc. And so I think there are a couple of elements which contributed. First of all, it was a time that was dedicated upfront to gathering and cleaning the data, where people had visibility and buy-in, both to the measures that would be used, but also then to see the data itself and understand that, yes, these are my patients, these are my results, and be comfortable with that before they were actually shared with any of the other institutions. So in fact, there was sort of a process of gathering the data and cleaning it, and then having blinded results, and then eventually you could see where you were, but not who the others were, to get to the stage of you could see where you were and you could see who the others were in terms of the best practices. The hospital CEOs themselves, in this case, actually drove a lot of the leadership. It was their decisions, and it took quite some time. It took probably over a year before they got to this level of wanting to do it, and all were comfortable with the approach, etc. So that is an upfront investment of time to make that happen. But then I think another key element was just making sure that the populations that they chose as the first couple of pilots that they looked at, breast cancer being among them, had a strong clinical champion. So they had a clinical leader at each of the hospitals who was very committed to this, who believed in the approach, and was willing to take on the challenges associated with seeing the data in a different way and getting to comfort level with that. So I think those are a couple of the contributing factors in terms of getting the leadership right and getting the clinicians engaged.
Thank you. Anyone else? Was there one more? No? Yeah. Yeah. Here we go.
Thanks. I just wanted to come back to the issue of no single authority, like that problem of who's driving this, and wondering whether what maybe Icham is doing to push out all of these results in a way that you know, there's way more encouragement for uptake in terms of, you know, wherever the institutions are across all of these different countries.
That's a great question. So, Icham, as I mentioned before, is an independent, not-for-profit. They're fairly small scale still, to be completely honest, but they have amazing impact. So, one of the things that they're trying to do is to do some structured benchmarking. The first step to that, they actually are working with some data scientists to transform their list of outcome measures, which we saw those little green segments of each of the wheels, to be more machine readable. And so this is a process where the work was presented just 2 weeks ago at a World Economic Forum summit meeting in Rotterdam in the Netherlands, and 4 of the 28 sets have now been both standardized and made machine readable. So that's one of the steps, I think, in terms of driving this forward, is making the ICHOM standard sets not just a concept that exists on paper for everyone to access, but rather actually something that you can sort of plug and play, if you will. Because I think the more user-friendly we can make the outcome measures themselves, that will help drive the uptake significantly. So in addition to ICHOM, and there's many initiatives, and I'm sure I'm not going to mention all of them, but the World Economic Forum, as I mentioned before, had the multiple year project. The conclusion of that in January of this year was the launch of the Global Coalition for Value in Healthcare. So the World Economic Forum is hosting this. There's actually, many of you in the room may know, Value-Based Healthcare Canada, as a new multi-stakeholder public-private partnership, is one of the first members of that global coalition, with the overlying goal that they will bring together similar types of coalitions who are working on the value-based healthcare enablers, be it defining and measuring the outcomes, or be it payment reform along value-based guidelines, working on the informatics piece, et cetera. So those are a couple of things that are trying to drive the uptake of value-based healthcare more broadly.
Can everybody hear me?
Yep, there you go, Louise. Back over to you.
I had forgotten how terrific that presentation was, to be honest. I remembered and learned things yet again that I always forget about value-based healthcare. I hope you enjoyed it as well. I don't know if there are questions. I'd like to make a couple of comments. First of all, those of you who know me on this call will know that social determinants of health are always on my mind, and so you will see, for those of you who've signed up for the summit, and those of you who haven't, I hope you will, that social determinants of health are a thread throughout all of the summit. And in fact, on the second day, which is December 3rd, we will be dealing with specific populations that are particularly adversely impacted by lack of access to social determinants of health. Fascinating panels. I've spoken to all the panelists, and I'm really excited about that. I hope you will be. On the third day, December the 8th, there was a reference by Jennifer to the new Value-Based Healthcare Canada initiative. And that's under the auspices of the Conference Board of Canada. And indeed, they, as I mentioned at the outset, they will be co-sponsoring that session. So it will be, I think you'll find it very interesting, because you will also hear from the 3 working groups that we set up after the last summit in 2019, which I know all of us think was a very long time ago. But those 3 have created a declaration of rights and obligations with regard to data, and those people who hold our data. I don't know that one of these has been written before, but we've written one now. We will also have presentations regarding the development of patient-reported outcome measures. And there's been a lot of work done on that by our working group. And we will also have a panel on integrated models of care. So what kind of models will allow for us to actually move towards value-based healthcare? Which brings me to my last comment, and that is, I've never been a big believer in thinking back to the past. You know, either with rose-colored glasses or not. In this case, I think there are a lot of rose-colored glasses about 2019, and I certainly understand why. But even back then, our healthcare systems were woefully under-resourced and, in my view, antiquated in terms of the way they were organized. And so this value-based healthcare for us is a way of changing that dial. And even though there's no doubt things couldn't feel more bleak at the moment, my life experience tells me that things do change. And the one thing that we can do with the past is not to repeat it and to move towards what Jennifer calls transformation. And in my view, transformation includes social determinants of health, and including people with lack of access to adequate social determinants of health, and also moving to a value-based healthcare system. So those are the reasons that I support the work that the value-based healthcare community is doing. Just to give you a bit of a context, at least from my perspective. I had no idea when we started this summit 5 years ago that we'd end up moving in that direction, but we have together, and we need to continue to do so. And frankly, I think it couldn't be more important than it is today to get those transformations in our healthcare system and the delivery of healthcare than today. So I don't know if you have any questions. Anybody got any questions? If not, oh, go ahead.
No, I was going to say I don't see that any have come in just quite yet. So we'll just keep an eye.
Why don't we show the social determinants of health presentation, and then perhaps that'll stimulate some questions at the end.
Excellent. Okay, here we go. Thanks, Louise.
Okay, hello everybody. It's great to be here. Thank you, Louise, and the Summit Committee for inviting me to be part of this every year. It's not just a privilege, it's an honor. And I would like to excuse from my voice up front. It is the blessing of the season, but I'm here nonetheless. So the Summit Committee asked me, and it's the green, right? Yeah. Asked me to speak about 3 things in particular. And I'll be touching upon the social determinants of health. I will describe how they impact access to care, and I will share my perspectives on value-based healthcare. And since we are all a bit delirious after lunch, and I need to redirect the blood flow from the tummies to the brain, I'm going to start with a pop quiz. And I won't put anybody on the spot. We'll just take votes. So let's read through this question. In the Greater Toronto Area, 1 in every 20 residents has difficulty making ends meet. B, 1 in every 50, and C, 1 in every 7. So let's just have a show of hands. Is it A, 1 in every 20? 1 in every 50? 1 in every 7? It really is 1 in every 7. And that's an astounding number. And you may be sitting there thinking, well, what does having difficulty making ends meet got to do with health? And the truth is it has a lot to do with health, probably more so than anything else. And I'll spend the next couple of minutes unpacking this for you. So these are the 3 ways in which access to resources typically shapes health outcomes. Number 1, by shaping the prerequisites for health. Do you have a warm place to live? Do you have enough food to eat? And I think those are pretty logical, right? But access to resources also impacts day-to-day stress. What is it like to live under conditions of constant deprivation and continuous activation of the stress response? Well, the body's biological mechanism is going to stay on continuously and impact the body's health system in a very simplistic way. And third, by limiting opportunities to make choices. Can I choose to buy the fresh fruits in the market? Can I choose the gym membership around the block? Can I even choose the phone plan that's going to allow me to dial my mom and release my stress? Well, opportunity to access resources shapes health in a multitude of ways. And if we look at this rainbow model, this describes the social determinants of health. And I, me, you, everybody, is just really the little red core of this rainbow. And our health is impacted by so many other things that layer upon ourselves. Is it the community where we live? Is it the place where we work? Is it the community where our housing is? How are my conditions when I go to pray? What is it like when my kids play? And eventually, all of these things are shaped by the social and public policies of where we live. And how important are they in shaping health outcomes? Well, take a look at this infographic from the Canadian Medical Association. 50% of our health is shaped by the social determinants of health. And whereas that's not my talk today is about the 25% that's shaped by access to healthcare. We may think, well, you know, in Canada, we have Canadian Medicare through the Canada Health Act, which I know Louise described in great detail this morning. So, you know, really, I mean, we have a publicly funded health system. What are we even talking about when it's access? I mean, we're not across the border in the United States, right? Why are we going to spend time even talking about this? So I thought I'd start by looking up the definition of access in the dictionary. And I just went online, looked at the Merriam-Webster dictionary, and this is what I found. So access is described as the ability to use, enter, or get near. And these are two very different concepts, right? So am I entering a place or am I using a place? And in healthcare, this is really important. And you can have the opportunity to get into a place, but you actually get in the door and use it. And that is the question that I'm going to try and answer for you today. So how do we describe access in healthcare? It's the use of personal health services to achieve the best possible health outcomes. So we have health services, thank you to our Canada Health Act. Are we able to use it? And are we able to achieve the best possible health outcomes? So really, it's three different things: entry, utilization, and outcomes. And let's take an example to understand utilization here. In Canada, we have extremely high rates of mortality related to lung cancer. And that is because tumors are found at a pretty advanced stage, when the tumor has already metastasized to the body and the chances for cure are pretty low. If we can find tumors at an early stage, when they're amenable to treatment, the chances for curative therapy are extremely high. Now, this is very promising to reduce lung cancer mortality. And now we have a health innovation that allows us to do just that. This machine uses low-dose CT scan to diagnose early-stage lung cancers. Very exciting. The premise is that there will be this encounter in the clinic where a physician is going to identify a patient who could be at a high risk of getting lung cancer and offer them the screening test. And the patient is going to say, oh yes, I absolutely want to do this screening test and improve my chances to live. Now, I'm not going to talk about how the physicians generally look. That's another topic for another day. But I will talk to you about how the patients tend to look. And there's a huge spectrum. Now, just taking these fictitious examples, but the reality wouldn't be far from what I'm about to share. If we look at John on one side, he's an executive working in his office. He can take the day off to go visit his physician. He's going to take the day off when he goes for a CT scan, and he's going to follow through on all of the recommendations that his doctors provide. He is the one who's going to find his tumor early, and he is the one that's going to survive lung cancer if he ever had one. David, my friend, on the other hand, doesn't even know what he's going to eat tonight. He's had chronic cough for a long time. If the doctor even mentions a screening test to him, the first thing on his mind is going to be, do you even know what my problems are? You're talking about me saving my life a couple of years from now, and I don't know what's going to happen tomorrow. And the truth is that utilization is impacted by so many different things. Age, gender, ethnicity, disability, resources such as income, food security, homelessness. And, well, we can talk about utilization, but do outcomes differ based on utilization? And again, let's just go back to lung cancer for a minute. And yes, outcomes do differ based on utilization. If we take a look at this graph, the bottom line represents the richest Canadians, and the top line takes a look at the poorest Canadians. And ever since forever, until to date, if you are poor, you are less likely to survive lung cancer. And I've just shared with you a couple of reasons why that might be the case. So where do we go from here, really? And what are the implications for value-based healthcare? Well, these are just a couple of my perspectives. And I take the definition of value from Porter, which is outcomes that matter to patients over the cost throughout the patient journey. And a general word of caution that I have is that when we know 50% of health outcomes are driven by the social determinants of health, we're putting a lot of emphasis on the healthcare system if we assume that just the healthcare system is going to drive health outcomes for the whole population. That in itself is a flawed assumption. So what does that mean when we consider value through the healthcare system? I would say, specifically because we are talking about cost, I'm going to put it in economic terms. If you want a return on investment, for every dollar you put into the healthcare system, you need to put at least $1 into social spending, if not $2, if you're going to drive total value for the population. And you really need a strengthened base of social services upon which to deliver health services if you are going to achieve that value at all. But my closing remark is really based on the appropriate integration of patient-identified priorities. And we've spoken a little bit about patient engagement. And what I would really like to say to everybody who's here right now, and for all of those who are patients or caregivers or funders or decision makers, when you have a seat at the table for an advisory committee or you're part of a board, use your voice to represent the voices that are not heard, the voices that are never going to make it to that seat at the table. It is our responsibility to share that voice if we have the privilege of being at that table. And if at all, we can find participatory ways of getting their voices at the table, then make every effort to be able to do so. That really is the closing point that I'd like to make. I will leave you with this image from United Way, which really shows the immense issue that we have when it comes to homelessness and housing insecurity. This tower, called the Unignorable Tower, represents the mammoth infrastructure we would need to house the 120,000 Canadians in the GTA currently facing housing insecurity. So really, what conversations do we need to be having? And where do we need to drive that value from? I'd be happy to take any questions now. Thank you.
Any questions or comments? Ambreen.
Hi, Ambreen. Thank you so much. I guess one of the things that concerns me is, I mentioned this morning, I believe everybody works on the punishment or reward system to do anything. And if I look at politicians, which I try not to, well, I actually do a lot, They just want to get reelected, and they want people with lots of money to fund their campaigns. So the people that you and I are talking about here and worrying about are not those people. So how do we? What's the risk and reward that we could argue to both the politicians and the bureaucrats for making these social changes? And I'd like to give an example, and maybe it's an example that you might know about. I read about 3 weeks ago that the University Health Network has put aside a plot of land by their hospital to house people who would otherwise spend days and days waiting in their emergency rooms because they realized it was cheaper to build them somewhere to stay than to have them sitting in their emergency rooms. I can see what the reward there was, but how do we get more of that kind of good behavior, and particularly at the political level?
Well, I think from that example in particular, they came to this conclusion that having people who were homeless meant that they kept using the emergency department, and the eventual cost of treating people who were homeless and returning to the emergency department, it's all about the return on investment, I guess, right? So they're extremely costly high-end users. So if we are able to house them, can we give them a safe place to stay so that overall improvement in their access to resources and health will reduce their consumption of the health system? Now, I think that's a great strategy, but I do think it's still one step removed. I think the question that someone really needs to put out there is, well, why are they homeless in the first place? Which cracks did they fall through? Where did our system fail them? They're not homeless because they choose to be. And I've spent a lot of time talking to patients who are homeless. No one chooses to be in that position. They're in that position quite simply because they fell through some cracks. So where do we need to seal those cracks so they're never homeless to begin with? It's what I call a Band-Aid solution, where housing is important. It's extremely important. But let's get to the policies that are allowing people to be homeless in the first place. And I think unless we confront politicians with those kind of tough questions, and particularly I would say I'm very privileged in the sense that I can stand up and say what I think and feel, and I'm not afraid of any repercussions to that. So unless we have more people in places of power that are able to speak the truth and question some assumptions that have been just left behind, let's put it under the rug, let's build a housing tower and let's not question why we'll need another 2 in another 3 decades, right? We're not really addressing the root problem. So we need to understand solutions and identify which are the tough questions that need to be asked.
I don't know if this is a question, more a comment. I completely agree with what you're saying. My issue is that you have to start somewhere, and Band-Aids are important. Absolutely. And sometimes before going into surgery, you need to stop the bleeding. So the way I see those things is, and it translates to everything. My lens is mental health, but it translates to everything. You have downstream intervention, that's like your critical issue you have to solve right now, homeless in the street using ER. And then you have your upstream intervention, which is prevention. Don't let them get homeless. You have to attack both of them at the same time, because you can't go upstream and let people die, and you cannot worry about the ones that are here dying and let these people get to the same place in 1 or 2 years. But what I see as one of the issues is that we have the same people doing both, and you can't. There is no sustainability. We have to engage people. We need people that are gonna worry about the people that are drowning now and make a human change and get them out of the water. And then you need other people that are gonna be up there building the bridge. But right now we have the same agencies doing both and getting burnt out and having resources, having to share resources for both. And obviously they go here because this is the urgent solution. So for me, there has to be a change of thinking. There has to be we have to understand that they're both equally important. I don't know in the rest of health. In mental health, I think it's 1% or 2% of the resources are dedicated to prevention. The rest are dedicated. We have to change that. We have to do it gradually, but you have to change it. And it can't be one or the other. You cannot just grab resources from here, put them here. No, you have to create new resources for intervention. You have to create new people. Get innovators there and get the people that are doing the day-to-day. Don't take from them. They need that. But I feel that that is the thinking that has to shift. So, sorry, because it wasn't a question.
No, I appreciate That was very well said. I think the fact that you made, the point that you made, which was we do need upstream and downstream interventions to happen in parallel, I think that's extremely important. I by no means mean to undermine the downstream interventions. That's where I spend a lot of my time working. But even within the same agency, whenever we spend our time either upstream or downstream, we tend to get so siloed and so focused on our own work that we lose sight of the big picture. And I think really the aim of my talk is to remind people that wherever you're working, don't lose sight of the elephant in the room, and just remember that it's there, and wherever you're working, it's important, but don't forget on what needs to be done overall, and that we're one piece of the puzzle wherever we are. Thank you.
There we go. Hi, Louise.
Hi. Well, I see that all of you seem to have stayed with us, so that I take that as a good sign. And I don't know if you have any questions. Again, I had forgotten what a great job Ambreen did for us yet again in contextualizing the issue of social determinants of health within the patient outcome context. So, Nat, do we have any questions at all?
I don't see any that have come in. Just checking both screens here. No, seems like everyone's very clear. Good information.
Oh, I'm going to take it as that. And I want to thank you again, all of you, for attending. And I hope that this has been a useful foundational webinar for your attendance at the summit. I really hope to see all of you there virtually. What a difference a year makes. But we have just an amazing array of presenters this year as well. And we certainly hope that you will join us. So without any further questions, we'll give you back a few minutes of your afternoon. Thanks so much.
Wonderful. Thanks, Louise. And thank you everyone for attending today. And if you haven't yet registered for this year's summit, you can see the link on the screen, and I'm sure we'll be communicating with you by email. So also, if you think of any questions later, feel free to be in touch with myself, Natalie at saveyourskin.ca, or better yet, with Louise directly, and her email is right there. So thank you everyone for attending, and with that, we will close.
Thanks, Nat.
Thank you, Louise. Bye-bye.